more in depth of a focused cardiovascular assessment, EKG review, and this is some medication review as well. Whenever we initially started talking about preoperative assessment here, really at the beginning of the program, summer, and then also in fall, we really just hit the absolute bare minimum basics to get you guys out in the clinical setting and get you guys talking to patients. Now that you guys have done, probably at least 100 cases, probably more, you've got to do a number of anesthetic assessments. And there's certainly a difference in a pre-anesthetic assessment and a true history and physical. However, you need to be able to do both. You need to be able to do both efficiently and effectively. Once again, these are recommended readings of all things Nagelhout, the 7th edition, chapter 20, for your preoperative assessment. That's going to be your go-to for not only studying for boards, but for honestly making you a good anesthesia provider. Miller does a great job, especially in their cardiovascular assessment section. It's very detailed. For the people that want to get that detailed information to really dive into it, highly recommend. And I think we talked about Dubin's EKG book, reading a page a day of that. You can download it on PDF. If you don't have it, let me know. I can get you a copy of it. If you read a page a day of that, you're going to be so much better at handling EKGs. And it depends on where you go. If you go somewhere that you're in a care team model and you're not, you're having a pre-op done for you, you should still ask some focused questions, but you might not have to look at EKGs as often as someone who's maybe in a more independent setting. But those are some skills that you need to have. So objectives today, we want to talk about surgical risk for the cardiac patient undergoing, and this is specifically referring to non-cardiac surgery. We're going to talk about how ischemic heart disease really affects anesthesia, some anesthetic techniques, and the risks and benefits of MAC, regional, and general. We're going to do some EKG review and then some medication review as well. So really to begin with, someone with cardiac disease undergoing any type of surgery is at a higher risk of developing perioperative complications, okay? And this is a statistic that is good to know. Cardiovascular complications account for 25 to 35% of mortality following non-cardiac surgery. So whenever patients ask us, what does it mean whenever I'm high risk? Or, why am I high risk? We need to be able to talk about these things. And there's this thing called the RCRI, that's the Revised Cardiac Risk Index. And these are predictors of major cardiac complications. When we think about high-risk procedures, okay, high-risk surgery, there are some things that come to mind. Maybe an open abdominal aneurysm, okay? Maybe we're doing a radical open nephrectomy, okay, or a cystectomy. Does someone have a history of ischemic heart disease? What's your indication for an arterial line? Why do we place an arterial line in somebody? Someone tell me. What's the textbook indication for it?
Continuous blood pressure monitoring?
Yeah, continuous blood pressure monitoring. But normally there's a little quip that goes along with that. Arterial lines are really useful in procedures where we expect fluid volume shifts, which would necessitate continuous blood pressure monitoring, and also somebody with cardiovascular disease, okay? Because maintaining that pressure at baseline is incredibly important. When someone has a history of congestive heart failure, okay, we need to ask about their ejection fraction. When was their last echo? Have things changed? How often does someone need an echo done? So if you have someone that has a history of CHF, and they're coming to you for outpatient surgery, okay, but you're in a hospital setting. Is a 6-month-old echo, is that too old? A 1-year-old echo, is that too old? 5-year-old? Okay. So here's the kicker to a lot of that. Okay, there's not really hard, fast, like, okay, it's 6 months in 1 day, we need a new echo, because truthfully, how quick can someone's ejection fraction change? Okay, 20 minutes, 30 minutes. Okay, so they could have had the echo yesterday, had an ischemic event that night, and come in, short of breath, crackles in their lungs. okay? The big indication for an echo additional testing is when there has been a change in their baseline functioning, okay? Have they went from stable angina to unstable angina? Are their feet this big around and a week ago they were normal sized? Okay, that's whenever we really need to get that further investigation. And the more risk factors that are present in a patient, the greater the probability of a perioperative complication. And when I say cardiac complication, I mean cardiac arrest, okay, ventricular fibrillation, heart block, pulmonary edema, and really preoperative testing should only be done if your results are likely to influence your perioperative management, okay? And you can add in there the risk factors for other major cardiac complications, cerebrovascular disease, insulin-dependent diabetes, okay, and that elevated creatinine greater than 2 preoperatively, okay? So think about these patients. No doubt you've cared for them. You know what they look like. You know what maybe complications that you've experienced with them. And this is where we really talk about risk stratification, okay? And whenever we ask for a patient to see a specialist before a surgery, we want you to see your cardiologist, we want you to see your pulmonologist, your nephrologist, okay? It's a misnomer to say we need clearance for anesthesia, clearance for surgery. We clear them for anesthesia. We want patient optimization. Are they as best managed as possible? And risk stratification. What are their risks from that specialist standpoint? And what are some things that we need to do in order to reduce those risks? Okay? Ultimately, anesthesia is our decision. Okay? So think about those predictors that I mentioned, those 6 predictors: the high-risk surgery, ischemic heart disease, CHF, cerebrovascular disease, insulin-dependent diabetes, and that elevated creatinine. The more risk factors that are present, the greater the probability of a perioperative complication. So let's start with a low risk. Patients that have less than a 1% chance of a major adverse event. No one in here, okay, no one in this room right now, okay, should be a 1% chance. Okay, that's 1 in 100. We are all healthy, mostly, you know, a lot of stress. We all have a lot of stress, okay, but we're ASA 1s and 2s, okay? When you think about these patients and you're really looking at that cardiac risk factors and that risk stratification, those are those patients that come in high-risk surgery, ischemic heart disease, CHF, okay? Now, those with an elevated risk, okay? So greater than a 1% chance, okay? They have more than 2 of those factors. So really none of us meet even the low-risk predictors. Stolting has a great section, I think it's page 96, for the cardiac risk factors as well. Now, continuing on a little bit, let's talk about some general considerations, okay? Think about valvular disease, okay? Does someone have a left-sided, maybe regurgitant lesion, okay? This is going to carry some higher risk, okay? But I would typically prefer regurgitant lesions, okay, over a stenotic lesion, okay? Age is considered a risk factor when you really associate with somebody who is incredibly frail or frailty. So we've all been in the hospital setting, okay, even if you came in with 1 year of brand new ICU nurse experience, okay, we've all been in the hospital setting probably at least 3 years. We've all seen someone who's like 50 years old that looks absolutely terrible, okay, and like, oh my gosh, they could die at any moment. Okay, maybe a 40-year-old. Now, to the flip side of that, have we all seen a 90-year-old that you're like, oh my gosh, you look better than my grandparents? You still drive? Oh, you were out on the golf course today? All right. So age is a risk factor when it's associated with that frailty, when you have less than 4 meds. Okay. There have been some updated AHA guidelines within the last couple months. However, for testing purposes, when you guys go and take boards, they are still going to go by what is in the textbooks, okay? Unless the NBCRNA updates their curriculum and specifically specifies these guidelines, we're going to go by what's taught in the textbooks, even though there are very few minor things that are different, okay? the newer guidelines, they don't categorize clinical predictors, okay, into that major, intermediate, and minor factors. Okay, that was an older thing. We really look at some clinical factors that increase the risk. Okay, those are going to be unstable coronary syndromes. So, like an acute MI, okay, less than a week before, or a recent. Recent is greater than a week, but less than a month. And these patients likely have an ischemic risk, whether it be by their clinical symptoms with unstable angina, or maybe they've had an invasive or non-invasive study. Maybe they've had a heart cath, maybe they've had an echo done, a stress test. It is suggested that more than 60 days should go by, at least 2 months, okay, before non-cardiac surgery is undertaken in the absence of coronary intervention, okay? At least 2 months. All right, we had a test question earlier today that we talked about somebody who had stents placed, all right, and they're scheduled for a vocal cord biopsy, something like that, for laryngeal carcinoma. Did anybody want to delay that case? No. Why is that? Why would we not delay that? This is an example I've used before because this was a real-world example. We're going to delay someone's cancer treatment for months? No. Okay? Sometimes you have to anesthetize these people, whether you want to or not. Okay? And if you think that's bad, wait till you have to go and get somebody from the unit. Okay? That's an ASA 5E that has to have surgery. All right? That the surgeon's saying, I don't even want to do it, but the family's going full court press. They want everything done. All right? And they're going to code in the hallway on the way down. All right, and they're maxed out on pressors, and you can't even give them any anesthesia. You bring them in the OR and you can give them rock and maybe a 0.5 milligram of Versed. I mean, it might be a miracle if they woke up and remembered everything, if they're that sick. But those are some incredibly unstable cases that all of you will do. Okay, so sometimes I think we get a little hesitant, a little too hesitant. Okay, we need to follow our guidelines, but we can do a lot of very, very sick patients, very, very sick cases without, a cardiac event happening. Unstable or severe angina. Okay, someone that has marked limitation of their physical activity with normal or basic pace, and then they have chest pain that becomes so severe that they can't continue on, all right, that's a big deal. Ask about that. Investigate it. When did it last happen? What do you do? How long did it last? Do they have decompensated heart failure? Okay. Are their legs swollen? That's one of the best things to check. Listen to somebody. Okay. Does anybody go to the OR without a stethoscope on? How many of you see your CRNAs walking around with a stethoscope on? Does every CRNA have one? No. Okay. Please don't be that person. Okay. Think about those severe valvular lesions. Specifically severe or critical aortic stenosis or severe mitral stenosis, okay? If you do TAVRs, you go somewhere that does a lot of TAVRs, you're going to be putting somebody to sleep with severe or critical aortic stenosis pretty often, okay? It can be done, and it can be done safely, all right? Think about those dysrhythmias, okay? High-grade AV blocks, okay? Mobitz type 2, for example, third-degree heart block. Okay, symptomatic supraventricular and ventricular tachydysrhythmias. Those all increase operative risk. Be familiar with these. Know which ones are going to be a big deal. I have them listed here. Severe, the stenotic lesions are typically worse than the regurgitant ones. Okay, so when someone asks you, what's my risk of having a heart attack? What's my risk of having this done? If you've had an MI less than 60 days prior to surgery, 1 in 5, 20%. Less than 30 days, 1 in 3. And if you have a reinfarction, your mortality rate is 50%. The highest at-risk period is surgery within 30 days of an MI. If you know you have to do surgery within 30 days of an MI, what kind of stents should they have placed, ideally? Bare metal. All right. Okay? It's so important that if they've survived that coronary revascularization and they don't have bare metal stents, those stents have time to endothelialize. Okay? If they reinfarct, all right, they're at incredibly high risk for morbidity and mortality. Okay, ADLs, we've talked about this. 4 METs, walking at 2 to 3 miles per hour, baking, slow dancing, golf, climbing a flight of stairs. Okay, somebody that presents for elective surgery with any unstable risk factors, okay, elective, unstable, should probably be delayed and optimized. Okay, so the elective gallbladder, okay, not somebody with a rotten, a gallbladder that's been in the hospital for 3 days with a drain. Okay, that's not elective. Somebody who's coming in from home for a robotic lap chole that has unstable angina. All right, they can probably wait another week. They can probably wait to get optimized. Okay, and we're not canceling surgeries, we're delaying them, we're canceling their anesthesia. We want to evaluate that functional capacity. Okay, we look at those METs. This is a good thing to know, the oxygen consumption. Okay, 3.5 milliliters per kilo per minute is 1 metabolic equivalent. Okay, metabolic equivalent of the task, technically, METs. Okay, less than 4 METs, poor functional capacity. Greater than 4, okay, good capacity. All right, there are activities of daily living, ADLs. All right, and there's a difference. Okay, there is a breakdown. There are your basic activities of daily living, okay, which are you're dressing yourself, okay, you're getting up, being able to go to the restroom, things like that. And then there are, I can't remember the adjective to describe them. I can't remember if it's independent. I'll look it up and tell you guys. But they're an assessment of if someone can live independently. One of those is cooking. One of those is cleaning. Okay, and so that's really whenever you get into formats, that's why it's really, really good to look at those things. So someone has good functional capacity, okay, that means that their heart rate will increase enough and decrease enough, all right, without some infarction or ischemia. So when we DL them and we shoot their heart rate up 30 or 40%, or we induce them and we drop their blood pressure 30%, all right, they're not going to have ischemia. Typically not, because they can have that wide range in blood pressure from the metabolic activity. So unstable clinical risk factors, okay, delay, proceed for emergency. Keep that in mind. All these things that we want to delay, if it's an emergency, we're going to go do them. Think about a trauma that we take in that, is got a hemoglobin of 3 that we're having to rush to the OR. We're going to take them back no matter what, okay? All right. Stable clinical factors, less than 4 METs, plus 2 or more, delay further evaluation, okay, for the revised cardiac risk index. And then greater than 4 METs, all right, with elevated and low risk, proceed to surgery. Less than 4 METs, with low risk, proceed to surgery. Okay, no high, intermediate, and low risk. Aortic surgery, big vascular cases, greater than 5%. Intermediate risk, okay, intraperitoneal, neurologic, major ortho procedures, major urologic procedures. And then low risk would be breast, reconstructive, dental, cataracts, minor orthopedic procedures, okay? Think about that. Keep that in mind whenever we're talking about these cardiac events. There's a clear association between the use of beta blockade and adverse outcomes. All right, the use of beta blockers is associated with a reduction in perioperative cardiac events. Continue the use of beta blockers. Why is that so important? Will someone tell me, why is it such a big deal that they take their beta blocker? Really, why is it? Yeah, okay. And what does anesthesia do? I mentioned it earlier. Think about the things that we do in anesthesia. Direct laryngoscopy, okay? Very, very stimulating. Okay, we try to block that SNS response, okay? And if you block it too much anesthetic gas, too much anesthetic agent, then you have hypotension. How does your body compensate? Typically increases your heart rate, all right? Increases your oxygen consumption. If you're not revascularized, all right, you're going to have some ischemia. Have they had recent angioplasty? Have they had stents? Okay? Now, I'm going to say something. Note this and write this down. There is no value in preoperative coronary intervention in a patient with stable ischemic heart disease. Okay? Stable ischemic heart disease. Okay, that means they have stable angina. Okay? We don't say, oh, well, you've had stents in the past. You're not complaining of any symptoms, but before we anesthetize you, I want you to have another heart cath. All right, just to make sure. That's not a thing. That doesn't exist. Okay? Now, there's a flip side to this. Acute administration of high-dose beta blockers in high-risk patients undergoing low-risk surgery is not recommended. Okay? So, giving a bunch of labetalol or metoprolol, okay, to someone, even if they're higher risk, even if they're on a beta blocker, not on a beta blocker, it's not recommended. Okay? Think about that. Even though they reduce myocardial oxygen consumption, even though they improve that oxygen dissociation from hemoglobin, they suppress that perioperative sympathetic response. Okay? We don't just start patients on beta blockers just because of it. Or, hey, we think that this would be a good thing. Okay, nitro. This is another good thing to keep in mind. Okay? It's good treatment for acute perioperative ischemia. But what's the downside to nitro? What does it do to that heart rate? It causes a reflex what? Yeah, it causes a reflex increase in heart rate. Okay? So we need to be careful whenever we're using drugs like nitro, all right, with how much we increase that heart rate. We have to balance that with ischemic events. And just because, we think, maybe they've had some ST changes. Well, let's throw some nitro on. Well, now are we having to press them? Or now did their blood pressure drop too much? You should probably have an arterial line if you're going to start giving nitro. All right. So based on the AHA guidelines, alpha-2 agonists for prevention of cardiac events is not recommended in patients undergoing non-cardiac surgery. Alpha-2 agonists are great. Okay. Clonidine, Precedex, they decrease that sympathetic outflow. Okay. Decrease that heart rate. What does a bolus dose of Precedex cause? Transient what? Hypertension. Okay. Has anybody seen that yet? Okay. If you have an arterial line in a patient, give them 10 mics of Precedex and watch that arterial line. Somewhere between a minute and 2 minutes, you're going to have that elevation. And it is shocking. It's a 20 or 30 point increase. All right. And I give a number of patients 20 mics of Precedex on the way back to the room pretty often. All right, and if you do that enough, you'll notice when you get if I take Noah or Connor back or one of the young healthy people, give them 20 mics Precedex, your first pressure in the room, depending on when you got that, it might be 160 over 100, and then your next one will be 110. All right, it's that much of an increase. Okay, be very careful with bolusing alpha-2 agonist, okay, to people with ischemic heart disease. Okay, small doses. Okay. Remember what your bolus dose of Precedex was in the unit? Okay, it's 1 mic per kilo over 10 minutes. That's a lot of Precedex. That causes some insane transient hypertension. Okay, continue their statins. Use of statins reduces that mortality in the perioperative period by almost half in non-cardiac surgery and over half, okay, in vascular procedures. Okay, so the pleiotropic effects. Okay, so having more than one effect. Statins stabilize that coronary plaque, they decrease that lipid oxidation, decrease inflammation, decrease cell death, stabilize that to prevent rupture and subsequent MIs. Continue their statins. So, the day of surgery, what medicine do they need to take? Their beta blocker and their statin. It's a whole lot easier to know the meds that they shouldn't take than it is to remember the meds that they should take. All right? We've talked about this in the last couple lectures, but hyperglycemia again. Perioperative glucose goal, below 180. How often should you be checking a glucose intra-op? I'll tell you, this is one of the things that I am worst about. Okay? This is like the last thing I think of. Okay? I want to be better about it. I'm gonna, I'm gonna work on that. But truthfully, if you have a diabetic patient and you've given them steroids or it's been more than an hour, all right, you should probably check a glucose just to make sure. Okay, we don't want to be too aggressive with treatment. For my people who've been nurses for a while, do you guys remember whenever it was a critical care goal to keep a blood glucose, it was like less than 110? Yeah, that was like a big thing whenever I went to work in the unit. And we had so many patients that were chronically hypoglycemic, or they'd go from, 210, 230 to 40, then we'd give them D50, and then they'd end up back on an insulin drip, and it was just insane. So 180, that's a good range. If you actually look up your hemoglobin A1C, a consistent blood glucose of 180 is actually still pretty elevated A1C. Okay. However, all right, we're not wanting to overshoot things. Okay, we're wanting to maintain things stable. So balance your multimodal therapy with your beta blockers, your statins, your insulin. And it's more beneficial to do this than just to use one, okay? Use everything. If you give your steroids early, you're going to have that elevated blood glucose. All right? It's not just going to sleep. It's not just, hey, I'm going to give you some propofol, and we'll go from there. All right? So there are two distinct complications associated with stent placement, okay? We have acute stent thrombosis and stent restenosis, okay? So acute stent thrombosis can lead to that abrupt occlusion of a coronary artery, okay, and cause an acute MI. Okay, acute stent thrombosis is a very serious complication, high mortality rate, high MI rate, okay? Now, thrombosis of a stent can occur anytime after a stent implantation. Okay, and any time antiplatelet therapy is abruptly discontinued. Okay, maybe that patient who knows that they should stop their blood thinners for 3 days says, well, I don't want to be canceled, I'm going to stop them for a week. Or, oh yeah, I forgot to pick my prescription up. All right, that abrupt discontinuation, very quickly they enter a pro-inflammatory state. Okay, most events of acute stent thrombosis occurs in the first 30 days after stent placement. Now, restenosis slowly develops, okay? All right? And this can be related to excessive endothelial growth, and that risk peaks at around 6 to 9 months after stent placement, okay? Coronary insufficiency, all right, is going to be your main symptom of restenosis, okay? Do you know what cardiac surgeons call cardiac stents? They're ticking time bombs. We better just go in there and get you some new grafts. All right, it's way better. You got a bunch of ticking time bombs in there. We just need to reroute everything. All right, because cardiac surgeons want to operate. Of course they do. All right, what do patients want? They want stents. In and out. You mean I can go home today, tomorrow? It's way easier. All right, know the difference between bare metal and drug-eluting. Okay, dual antiplatelet therapy, okay? Your P2Y12 inhibitors, okay? Be familiar with these. Aspirin should pretty much be continued indefinitely, all right? Holding everything, dual antiplatelet therapy and holding aspirin, is rarely a good thing, okay? And who should be the one to make the decision on to stop someone's anticoagulation? Whoever's prescribing it, okay? Surgeons can make a request, all right, but really whoever is prescribing that anticoagulation should be the one deciding if they should go off of it. This is the box from Nagelhout, 3811, perioperative considerations for patients with a coronary stent. This is a very good box to review for elective surgery and elective non-cardiac surgery and antiplatelet therapy. So this is a fairly simple graph, love it. So stent placement on the left-hand side, 0 days, 30 days, 3 months, 6 months. Okay, bare metal stent, drug-eluting, bare metal on the left, drug-eluting on the right. All right. Notice how it breaks it down to class 3, okay, class 1, class 2. All right. What happens if we delay a procedure? Okay. Well, if someone is at risk for harm, or like I mentioned, that laryngeal carcinoma is a great example of it. Okay. Delaying them would cause harm. Okay. All right. We would probably proceed with it. All right. Now, if it's something like that Gallbladder, that elective, hey, I've had problems for months. All right, we're probably going to wait till at least that 3 to 6 month range. Okay, it used to be a year, then it became 6 months, and it's in the newer guidelines. There's a few caveats in there for 90 days. All right, and you'll see that more and more. The newer stents are better. Okay, they're less likely to have issues, but once again, delaying surgery, if there's a risk of harm and if it outweighs your risk of stopping or waiting, you're going to go to the OR. Sometimes you'll see patients who are bridged, okay? So if you interrupt dual antiplatelet therapy, aspirin should ideally be continued. And there's a bridging involved, okay? Sometimes you'll see it where we use drugs like heparin or Lovenox to bridge them, and they're administered up to 6 hours, okay, before the surgery, with the goal of preventing stent rethrombosis rather than going without your dual antiplatelet therapy for 3 to 5 days. And ideally, restart your dual antiplatelet therapy as soon as you can. Okay? Pacemaker and ICDs. This should happen, and it does not happen the majority of the time. All devices should be interrogated prior to surgery with a copy on the chart. And you should know what happens whenever you put a magnet on somebody. You should know what their baseline or underlying rhythm is. Why do they have the device? Okay? So assess it in pre-op. Okay? Look at their heart rate. Do you see pacing spikes? You should always have a magnet available, especially for surgery involving cautery. Ideally, bipolar, and this is especially for AICDs, okay? Bipolar cautery is incredibly useful. However, does anyone know, is anybody a surgical tech beforehand? Okay, does anyone know the difference between bipolar and monopolar cautery? Okay, bipolar cautery is not going to be as aggressive, and it's going to take a lot longer, okay, because it's a bipolar current, okay? It's not the traditional Bovie of just shh, and you're able to cauterize everything. Bipolar cautery takes time, all right? Surgeons don't like to use it, okay? So, for example, say you're doing a carotid, okay? Very rarely will they use bipolar cautery. They want monopolar, okay? All right, and so they want you to do whatever you can to not force them to use bipolar cautery, okay? Ideally, if you're more than a foot away from pacemaker and you're working on the leg, all right, and you've got your return pad down there, all right, that current should not be going up, but you should have your magnet closely available. Prone cases, okay, say you're doing a big C-spine case, all right, and they don't want to use bipolar cautery, but your patient's going to be prone upside down, and they have an AICD. How do you secure that magnet on? Yeah, tape it and tape it real good, right? Also probably have some padding, some cushioning. Imagine somebody on that magnet for 10, 12 hours for a big case. Like it, I like it. I've seen the big Pop-Tart Tegaderms. Those look good over it. Foam donut pillow, whatever you can, just make sure to pad it as well. When someone has an AICD and you're doing, say, orthopedic procedures, all right? One of my least favorite things I've ever had happen before, sitting beach chair case, had a magnet on, all right? They're pulling on the arm, magnet slides off, all right? I only noticed it because the heart rate changed, because when the magnet was on, they were back at their pacing rate of like 80. All of a sudden it changed, and they were about to go, like, hold on, wait 1 second. And I'd start feeling around, like, okay, my magnet's off, way down here, okay? Sitting cases, be very, very careful, okay? Ensure you have it. Grounding pad should be as close to the surgical site as possible. And if you have it, if you put a magnet on, ideally it should be reinterrogated afterwards. Does that happen all the time? No. All right? But the appropriate thing, especially for testing purposes, is to have it interrogated. Okay, so pre-op evaluation. Whenever you're thinking about that cardiac risk assessment, okay? What's their overall appearance? Truncal obesity, do they have Cushing's disease? Measure their blood pressure in both arms. Why is that? Well, if somebody has subclavian stenosis, all right, you may put an A-line in, one arm that reads 90/40, and the other arm's reading 180/100. Okay, that's really, really frustrating. Okay, do they have, do a fundoscopic exam. Do they have hypertensive retinopathy? Bruits, distended neck veins, okay, enlarged thyroid. Listen to their heart. For my people that are going to come out and be really, really good with POCUS, throw a probe on their chest if you have any doubt, okay? Listen to their lungs. Note their extremities, especially assessing their feet for any swelling and edema, all right? There's a patient I had probably a month or two ago, and I was not going to pull back the sheets anyways, but I'm like, oh, let me look at their feet, because they had said that they went to the ER recently, and their legs were swollen. What happened in the ER? Oh, they gave me some IV Lasix. Repeat a bunch. Good. All right. He's like, yeah. He's like, I probably need some more Lasix, though. He's like, feet are swelling again. All right. Gave him some Lasix in the back. He was still able to go home and get discharged, but I wrote on there for him to follow up with primary care within a week, all right, because his diuretic dose needed to increase, all right. So this is a great example of evaluating your patients, knowing what they need, and of course, being very careful with the amount of IV fluids we give, okay? Any alterations in their gait, their deep tendon reflexes, their mental status, speech, cranial nerve abnormalities, note those. Limb ischemia, okay? Note if their limbs are cold. Do they have Raynaud's disease? Raynaud's phenomenon. Okay, hypertensive retinopathy, which, I don't know how often we're going to truly do this, but I think it's a good thing to be able to at least answer questions on. And if you have a student with you and you have somebody that has hypertensive retinopathy, this is a great thing to teach somebody. Go look at their eyes, okay? Do you see those cotton wool spots? Do you see that flame hemorrhage, okay? Do you see that damage? Okay. Surgery and anesthesia can result in a lot of sympathetic stimulation, inflammation, hypercoagulability. Hemodynamic instability is incredibly common. Acute blood loss, hypothermia, keeping patients warm. If someone has sickle cell traits, sickle cell disease, keeping them warm. All right, one of my favorite tricks, underbody bear hugger, overbody bear hugger. You can have two, no reason you can't. All right. For a big aneurysm case, if we're doing an open abdominal aneurysm, I always have an underbody bear hugger, and then I always have an upper one on. Okay, because I know they're going to get cold. We've got these big retractors in, they're going to irrigate, they're going to lose so much fluid. Keep your patients warm. That's one of the biggest things for not only proper management of trauma cases, but any big vascular case, all right, especially when you have a lot of bleeding, all right, is the patient warm? Assessment of their contributing factors or the presence of angina, dyspnea, and syncope. Okay, good baseline blood pressure in both arms. If you have a discrepancy, which arm do you go by? Whichever one is the highest. Ideally, where do you want to place your A-line? In that arm. Okay? What if you can't get a radial arterial line on somebody? Where do you go next? All right, you could go brachial. What's another option? Say what? Yep, axillary. What's the benefit of an axillary A-line versus a brachial? Collateral circulation. Okay, so if you occlude your brachial, all right, you clot it off, probably going to lose hand and arm. You occlude your radial, probably going to lose some fingers. All right, axillary, even though you do it like a central line, should be completely sterile. It's very useful, especially in somebody that has severe disease. All right, and there's nothing wrong with the femoral. The only downside to the femoral is it's dirty. Assess their labs, coag specifically. Review their meds, make sure they've taken the things that they need to have the day of surgery. Okay? I hate that they turned 120/80, okay, into elevated. Okay, that should be less than 120/80 for normal. I find that so annoying. Know your stages of hypertension. okay, elevated or abnormal, and then you have stage 1, 2, and 3 of hypertension. Delaying surgery in patients with mild to moderate hypertension, only for blood pressure control, is likely to not reduce any perioperative risk. However, greater than 180 over 110, okay, greater than 180 over 110, all right, it's whenever you need to start assessing it. Because less than that, okay, it's not an independent risk factor for a perioperative cardiovascular complication. However, if somebody comes in and they're 180 over 109, okay, they're auto-regulated, and they've shifted that curve far to the right, 20% of baseline ideally, okay? So let's not shoot for 110 over 70. All right, that's going to be way too far off. They're going to feel like absolute crap. You're going to stand them up in PACU or phase 2, and they're going to fall and hit the ground, okay? Now, truly uncontrolled hypertension, malignant hypertension, hypertensive urgency, all right, that's whenever you want to pause. But that's somebody that's probably completely out of control. If you had to give an antihypertensive, all right, preoperatively, what would you give and why? Someone justify something to me. Okay, depending on what their heart rate is, I like that. Okay. Start with, what do they normally take? All right. Did they take it? All right. Probably don't want to give them their ACE inhibitor before surgery. All right. But balance heart rate, balance also the type of surgery. Now, if they come in really hypertensive and they're having, say, shoulder surgery done, okay, be very careful with extremes of positioning, because you may give that antihypertensive and then you may anesthetize them, and then they end up really dropping in the back, okay? Depending on what you're doing, depending on their risk factors, this is where you independently assess things. If you do have somebody that has severe hypertension and they're having beach chair surgery and you're going to proceed forward, put an A-line in and tape the transducer at the auricle of the ear, okay? This way you can appropriately press them. And you'll be surprised at how much it takes to get a map of 65 to the head. And this really comes down to, what type of anesthesia are we going to use? Which one is better than the other? Max, Tevas, regional, narcotic? Well, there's really not one that I can say is the absolute best. Reducing your SVR too much can be dangerous, okay, due to a relatively fixed cardiac output. Keeping that atrial kick is very important for right ventricular filling. Aggressively controlling hypoxia, hypercarbia, and acidosis. All right. If you do an epidural, all right, it's very useful for slow dosing. Spinals, consider that on a case-by-case basis. The basic challenge to induction and maintenance in somebody with ischemic heart disease is preventing ischemia by optimizing myocardial oxygen supply and reducing demand, monitoring for ischemia, and treating it if it develops. Okay? Control persistent tachycardia, control hypertension and hypotension, anticipate SNS stimulation. Okay? So what would that mean? That means if you know you're about to DL, control that heart rate. What's a great drug to help control that abrupt increase in heart rate during direct laryngoscopy? Esmolol. So useful. All right, Esmolol is a great drug for these cases. Why? Because it's gone so quickly. You're not married to it. You're not stuck with it for hours and hours and hours. Okay? Etomidate has some advantages for preserving stroke volume and cardiac output. Opioids can be very safe, all right, very cardiac stable, reducing that sympathetic stimulation. Okay, propofol can be useful, small, slow doses. Okay, neuromuscular blockers, they're pretty much all safe. There are some ones that are probably best avoided, okay, or best probably, depending on risk versus benefit. Everybody see that Sugammadex is approved in children under 2 now, infants to 2 years of age. So Sugammadex can be used in anyone, even though lots of places have been doing that for years. It's good to know that even from the manufacturer, they're sending out those guidelines. Okay? And then keep in mind, if you need an arterial line, if you think you might need one, put one in. Okay? If you know your arms are going to be tucked during the case and you're not going to have access to it, put your A-line in beforehand. Okay? I'm a big fan of a pre-induction A-line. If you think you need a central line, if you think you need a swan, go ahead and put it in. Don't wait. Know about your potent pulmonary vasodilators, what you have available, and what is commonly used. Okay, max. The benefits, it does not significantly alter tissue oxygen demand. Okay? Truthfully, MAC cases sometimes are very challenging because you run that risk of underdosing versus overdosing. You drop that blood pressure, you drop that SVR, you drop that heart rate. If they're undertreated, you get that tachycardic response. They hypoventilate. All right? So downsides to MACs. Still going to be moving. All right? And what happens whenever you're doing a MAC case and the patient starts to move? What does the surgeon immediately say? They're moving, they're waking up, they're not asleep. All right? A really, really good surgeon will say, it's all right, I'm just injecting some local, or we're almost done. A really good surgeon will talk to the patient. All right? There are very, very few really good surgeons out there. The majority of them are going to turn to you. You said, well, you said a MAC would be fine. What's MAC stand for? Mostly apneic and cyanotic, okay? Moving and crying, I don't know. All sorts of good acronyms, okay? MACs, very challenging because you're not controlling their respiratory rate. They have moderate pulmonary hypertension, okay? And now we cause them to hypoventilate, okay? And I've noticed, man, their pressure I'm having to treat it more and more. Why are they so soft right now? Okay, I'm only giving my propofol at 50. All right, well, they've hypoventilated this entire time. You've elevated their PA pressures. All right, everybody uses an oxy mask, right? Some end-tidal CO2 monitoring. Okay, is that quantitative or qualitative? Like an endo, when you guys, are we focused on that number that it gives us or the waveform? Okay, we're focused on that qualitative waveform. Okay, but truthfully, you're not getting a good quantitative reading like you would if you were intubated. Now, really, if you want to check your gradient, what do you have to do? You have to run a blood gas, all right? But it's a whole lot easier to say, okay, hey, I've got them on the vent. They're getting 6 liters a minute ventilation. My end-tidal's reading 35. Odds are I'm not 50. Okay, odds are my gradient's probably that 4 to 6 range. But if you have somebody that you're doing a portacathon and you give them some fentanyl and they're breathing 8 times a minute, and you see a nice good waveform, you don't know what their end-tidal is. Okay, now you can be really, really cool and you can put a connector piece, and if they have an oral airway in, you can shove it in there and get a really good quantitative reading. Okay, but it's still not going to be as accurate as end-tidal CO2. That's the downside of a MAC. Regional blocks, wonderful, great, if the patient can sit still and if they can be wide awake for it. The downside, last, okay, coagulopathies, all right? You need to be very cautious if you're doing a block and it's somewhere that you cannot hold pressure, all right? So if you're doing, same thing with central lines, okay? Axillary subclavian, if you can't hold pressure over an artery, over an area that you have bleeding, you probably shouldn't stick a needle there, okay? And then if you have to block somebody, but then you have to sedate that patient, all right, you're probably still going to have a number of issues because you're really doing 2 anesthetics, all right? The downside to a block, okay? Oftentimes, very, very sick vascular patients are coming in for amputations, okay? BKA. AKAs are really hard to do, really hard to get with truly just a block, okay? But a nice BKA, all right, or a foot amp, toe amp. They don't want to be awake, okay? They don't want to remember that. Okay, what are some things you can do? Earplugs are great. Headphones, if they have them. You probably don't want to take your AirPods out and say, here, put these in your ear. If you are that person, by all means, you are so nice. Get a pair of hospital-approved AirPods. I don't know. It'd be disgusting. All right, but do something to distract that patient. Some of these patients are incredibly sick. If they have an EF of 15% and they have to have an BKA, all right, yes, I want to do a block, but I'm going to have to probably give them something. Okay, if they're not on a chronic benzo, give them some Versed and Reverse at the end. Okay, there's no reversal for Prestex in humans. So if you overdo it with Prestex, you may have them on Levophed by the end of the case because they've had so much. Pay very close attention to how much sedation you have to give. All right, general anesthesia, we love it. Decrease myocardial oxygen demand, I control everything, and you're asleep. Okay? It reduces that psychological stress. It stops them from moving. Oh, but you got all that sympathetic stimulation. You got all that hypotension. However, sometimes, all right, you can give less drugs in a general because they're paralyzed than you would in a MAC. Okay? So if we have somebody sick in front of us, all right, we are very gentle going to sleep, all right, I paralyze them, put an easy tube in, and I biz them down, or if you're using the SED line, you know, we're shooting for a biz of less than 60, or shooting for a PSI of 25 to 50. All right, now run their propofol at, say, 50 mics per kilo per minute. All right, they're probably going to be pretty close to that, depending on how stimulating that case is, not heart surgery, but depending on how stimulating it is, they'll probably be pretty close to that general anesthetic depth. However, if we had them on 50 mics per kilo of propofol and you were macking them and they could move, they're going to be moving. I mean, how many times have we done a colonoscopy and you've seen someone trying to jump off the bed and their propofol's at 200 or 250 if you're using a syringe pump? Okay? They don't remember that, but they're running away from you. So keep in mind, go back to your MAC values, okay? Minimum alveolar concentration. What's awareness and what's awake? You know, awake 0.2, aware 4.5. Okay, abolishing movement, MAC bar 1.5. All right, same thing with, you know, monitored anesthesia care. If you want to prevent somebody from moving, you have to give a whole lot more than just to prevent them from remembering. Okay, so sometimes you can actually get away with giving less meds by doing a general. All right, ketamine, great, but it's going to cause some sympathetic stimulation. It may cause your BIS or your PSI to not be as accurate. That psychological and psychological distress in the recovery room. All right, Versed, Prestex for people who get ketamine, I think is very useful. Intraoperatively, okay, prevention and management of ischemia. Optimize their myocardial oxygen supply, reduce their demand, monitor and control their blood pressure and heart rate, keep them close to baseline. Anticipate simulation. Okay, if you've not given a mic per kilo of fentanyl and they're about to make incision, and you don't want to give any more narcotic, you better give some Esmol if you've got somebody that is likely to be ischemic if they have an increase in their heart rate. Okay? Hypertension is better than hypotension. All right? Stable bradycardia is better than tachycardia. All right? Don't let somebody become hypoxic. Ventilate them. I had a case, I guess it would have been last week. I had a student with me. They were trying to intubate, couldn't get it, and our stats went from 100, 99, 98, 97. And at 97, I said, hey, let's go ahead and mask them. And they literally looked up and they said, okay, their stats are 97%. I said, I know, I want to mask them. Okay, and they listened. All right, by the time they put everything down, put the oral airway in, and they went back to like, no, let's just do a two-hand mask. Okay, we're masking them. We're getting in title. Their stats dropped all the way to 70. All right, and it took us a couple minutes to get them back up to 100. All right, imagine if we hadn't stopped at 97% and said, hey, let's go ahead and do this now. All right, and they're like, how did you know that was going to happen? I'm like, I've done this enough. All right, but also we had a very prolonged apneic time. You tried for over a minute to intubate them. Okay, all right, and you know there's a delay. I'm like, you have to keep that in mind. So control that. If you're, this is a great example. Go to a video laryngoscope from the beginning. All right, what do you have to prove to somebody by doing direct laryngoscopy and potentially struggling and getting somebody hypoxic? Nothing. No one's going to sit there and judge you for doing using a McGrath, or they shouldn't at least. Okay, when that's probably the easiest and the best thing to do in most situations that could be challenging like that. But they will judge you when your patient's hypoxic. All right, they will judge you when that kid turns blue. All right. Same thing with turnover times. I was talking about this yesterday. Today, no one's going to think about our turnover times, all right, in Pete's Dental, all right, whenever we were slow, because we were trying to wake these kids all the way up, all right? But if we had a kid that turned blue and we had to do CPR on, or we had a horrible spasm packet, they're still going to be talking about that the next day, okay? Safety. When you guys are new, or even right now, and I know, some places are, well, we want you to be quicker. I want you to be safe, all right? Speed's going to come in time, but safety is the number one. All right. So when it comes to myocardial injury or infarction, this can be from a number of things: inflammatory response, that neuroendocrine stress response, and these are some things you can do. These are some ways to control it. All right. And we've talked about all of these. Blunt that sympathetic stimulation. How can we do that? All right. Say we're intubating. LTAs, IV lidocaine, esmolol, fentanyl, Remy, Precedex, MAG. All of these things can be very, very useful. Our volatile agents, they decrease that oxygen requirement, but they're vasodilators. They're going to drop that blood pressure. This can decrease your coronary perfusion, okay? And, you know, the textbooks will get into it, which one has more influence on coronary steel. There's not truthfully a preferred volatile anesthetic agent, okay? And even the current AHA guidelines state that volatile or TIVA is reasonable for somebody undergoing non-cardiac surgery, and the choice should be determined by their other risk factors and the prevention of ischemia. Whatever you are most skilled with, okay? All volatiles are myocardial depressants, okay? Nitrous can cause a little SNS response, may increase SVR. I'm a big fan of Ativa, but it's whatever you want to do. All right, your muscle relaxants. You can use all of these, especially cisatracurium, atracurium. Those can be utilized, but if you're really focused on that prevention of ischemia, avoid anything that causes histamine release. Avoid anything that might cause that reflex tachycardia. I don't know anywhere. Has anyone seen pancuronium on formulary? Okay. If you do, supposedly it's still out there. I've yet to see it in practice, but you know, it's great you get that reflex increase in heart rate. But ideally, probably ROC, probably VEC, probably cisatracurium. So, severely impaired left ventricular functioning, consider Ativa, okay, opioid-based anesthetic. That doesn't mean a heavy narcotic induction. You don't have to give everybody a milligram of fentanyl, okay? But that anesthesia-induced myocardial depression from propofol, okay, can be very dangerous. Opioids are often very good at reducing that SNS stimulation. A little bit of nitrous, the old school way of handling aortic stenosis, a lot of these sick cases was narcotics and nitrous. Okay, bunch of opioids, little bit of nitrous, just enough to get them through. Okay, add a benzo in there. Okay, enough to prevent that awareness. Okay, you'd be surprised that, once again, we talked about MAC-aware and MAC-awake, and those values, remember, are based off of no other drugs. If you've got a milligram of Versed in there, a little bit of Prestex, a little bit of narcotic, all that reduces your anesthetic requirements. Keep that blood pressure within 20% of baseline. All right, somebody with a severely impaired left ventricle, all right, benzodiazepines to ensure that amnesia. Be very careful with neuraxial anesthesia. Ideally, an epidural to slowly and carefully dose it. Early detection is the best thing you can do. Monitoring. What are the two most important leads? Leads 2 and V5 for ischemic monitoring. We'll talk about that here in a little bit. Monitor their ST segments, okay? You should be able to, if you don't have the ability to go back and review your entire EKG from that case, when you get in the OR, you should print a strip. So this way you have something to compare to baseline, okay? I would think most monitors now have that ability to review the entire case, but if you don't, you should have a strip, you should have a baseline, okay? Look at their T waves, okay? You want to know where that ischemia is, okay? So V5, fifth intercostal mid-axillary line, it's going to look at that left ventricle, okay? The LAD, lead 2, is going to detect ischemia in the right coronary artery, okay? That's going to be your blood supply for the SA and AV nodes, and you're going to really see those rhythm disturbances. Ideally, you should have them both pulled up, okay? Myocardial ischemia incidence is lower in the intraoperative period compared to preoperative or postoperative. What's the most dangerous times of flying, takeoff and landing? What's the most dangerous times of anesthesia? Okay, induction and emergence. Who here, like whenever you're waking somebody up, when do you take your EKG leads off? When do you normally do it? Tim, what do you do?
We take them off once the patient is extubated.
Okay, good, right. I see so many people pull their leads off, okay, before somebody is extubated. What happens at extubation? You normally have an increase in heart rate, all right, a change in blood pressure. For somebody with ischemia, all right, keep your EKG leads on. I'm telling you, you're more likely to have ischemia, induction and emergence, okay, than intraoperative. Keep your leads on. I can't tell you how many times I see people pull them off. And then, especially if like they have an A line, while we're watching their blood pressure, yeah, you should probably be watching, lead 2 and V5 as well. So keep that in mind whenever you're waking these patients up. And you'll see CRNAs do it, you'll see anesthesiologists do it, because they're wanting to hurry, okay? But rushing to save 5 minutes and causing an ischemic event, it's not really a good trade-off. Swans, truthfully, intraoperative TE is probably better than a swan. Now, if you're somewhere that is old school and you're still using swans, great, but TE is going to be the gold standard for intraoperative diagnosis of MI or acute changes, okay? High-risk patients, it's not benign, nothing's benign, okay? You can have a esophageal injury, you can have perforation. If you have somebody with varices, bleeding, strictures, okay? TTE could also be very useful, but if you've got full chest prepped, something like that, it's going to be a little hard to do, all right? But you can get so much more information dropping a quick TE probe, all right, and doing a very focused assessment, all right, then you take the time to put in a 9 French Mac, float a swan, do all those things. Control intraoperative hypertension, okay? All right, so how do you treat this? Well, you can increase your depth of anesthesia, but what's causing it? Is this pain? All right, and really stimulation is a nice buzzword for pain. If they were awake, it would be painful, okay, but they're asleep, they're anesthetized, they're in a medically induced coma, they're not really asleep, okay? So how can we block it? All right, is this a hypoxic problem? Is this a hypercapnic problem? If it's pain, give narcotic. If it's hypoxic, ventilate. If they're hypercapnic, increase their ventilation. Hydralazine, keep in mind, has that delayed onset, okay? It also is not really great for patients with CAD, reflex increase in heart rate, okay? If you want a quick on, quick off drug in their bradycardic, sure, a little bit of IV nitro. But Cardine, okay, fairly useful. Esmolol, fairly useful. But keep in mind, what reflex action are we going to have on that heart rate? All right, and you're more likely to have ischemia with tachycardia than with hypertension. Okay? You're going to begin treatment for ischemia when you have a 1 millimeter ST segment change or an adverse change in your heart rate or blood pressure. Okay? Hypertension. All right? If you use nitro for that coronary vasodilation, it will decrease your preload. All right, what's it going to do to your heart rate? If they're tachycardic, Esmolol is great. Okay? But if you give Esmolol and it goes away in 10 minutes and they're back tachycardic again, can you give more? Of course. You can do an Esmolol drip on somebody. All right? And if you really, really like the effects you get from Esmolol, if you want to give metoprolol, you can, but you're stuck with it. If something changes intraoperatively, okay, you've now beta blocked them for 3 to 4 hours. So if somebody is hypotensive, okay, restore their coronary perfusion. Do they need fluids? Okay? If you have somebody who's unstable, inotropes, do they need a balloon pump? Do they need an Impella? All right? Get good control. If you anticipate, say you have an EF of 35%, 35%, okay, and it's going to be a big case, all right, and you anticipate needing a vasopressor infusion, all right, there's nothing wrong with starting with Levophed, okay, especially with that reduced ejection fraction. I see a lot of people who make that mistake of we're just so used to Neo, we're just so used to ordering a Neo drip that they start with a Neo drip and then they're on 100 mics per minute in Neo and then they want to switch over to Levophed. If that's what your gut tells you, if that's the right thing to do, start with it. Okay? Now, postoperative management. Early extubation is ideal. Smooth emergence, IV lidocaine, magnesium. Okay? Slowly taking down your ET tube cuff. Doing everything you can to prevent that sympathetic response. Do they need calcium channel blockers? Esmolol on emergence. I've done it before, seen it done the first time I saw it. Someone else did it. I thought, oh my gosh, this is going to be horrible. They pushed all 100 milligrams, all one vial of Esmolol. Somebody was coming off the table, their heart rate is 120, 130. And I thought to myself, like, this is going to be terrible. Nope, heart rate dropped to about 45 or 50. All right. It's back up to 60 or 70 in about 10 minutes. They were fine. I'm not saying do that on everybody, especially old, frail people. The weight-based dose of Esmolol is like, literally, it's like 0.5 to 1. Okay? I'd stick to that 0.5, but you'll see so many people in the clinical setting give 10 of Esmolol, give a cc, and it's basically nothing. Like sprinkle some saline on their head. It's almost nothing. Okay? If your blood pressure is above 180 systolic, above 110 diastolic, that's going to be your highest risk. Okay? Avoid increases in your myocardial oxygen demand. Hypothermia. Shivering increases that myocardial oxygen demand. Control their pain. Okay? Maintain their hemoglobin. Somebody with severe CAD, they may feel like absolute crap at a hemoglobin of 7. You may need to keep them tanked up at 9 or 10, and that's okay. Most cardiac events occur in the first 48 hours post-op, but up to 30 days after surgery. Continue your intraoperative beta blockers and statins. This is key here. Now we're going to talk about a couple things that you're not going to see as often, but you should know about and we'll probably see on boards. Cardiac tumors. Okay? Primary cardiac tumors are fairly rare. Metastatic is a little bit more common. You're going to see TEE done. And oftentimes these are carcinoid-based tumors. Octreotide, okay, that's a somatostatin analog. Bolus along with an infusion. And then hypotension is often treated with additional boluses along with your vasoactive drugs. Vasopressin is also considered safe. Avoid anything histamine releasing, okay? Morphine, Demerol, atracurium, things like that. Hypotension from carcinoid tumors is often from manipulation. In the transplanted heart, it has no sympathetic, parasympathetic, or sensory innervation, okay? And the loss of vagal tone results in a higher than normal resting heart rate. Okay, that resting heart rate's normally 100 to 120, okay? Responses to circulating catecholamines is normal because of increased sensitivity, but they're very preload dependent, okay? So that blunted response to pain, okay, because there's no sympathectomy to intubation, so pay very close attention. It's very volume sensitive, all right? And I'm a big believer in this. If you're going to take care of somebody who's had a heart transplant, it should probably be at a place that can actually take them to the OR. Okay, unless you're doing cataract surgery, unless you're doing something incredibly minor, all right, they should probably be done in a place where they have access to a surgeon who could take care of them if they have an issue. So, preoperatively, ischemia is fairly silent. Make sure that they're on their immunosuppressives. Okay? And then what goes along with immunosuppression? Nephrotoxicity, infections, bone marrow suppression. Stress dose steroids are often needed. Note that double P wave on their EKG. The SA node is usually intact from the patient. So both it and the transplanted heart are going to send an electrical signal, so you're going to see that double P wave. A first degree AV block is fairly common. And even though it's firing, it's not going to, the SA node is not going to transmit that impulse, okay, because it can't traverse that suture line. All right, they have an increased PR interval. Neo works a little bit better than ephedrine. And you should probably have epi available to increase the heart rate. A-line for pretty much all these cases. Vagolytics, atropine will not increase the heart rate. Anticholinesterases, neosigmine will not slow the heart rate. Okay? Indirect acting sympathomimetics. Ephedrine has that blunted effect. Okay? But if you do give, say you're somewhere that doesn't have, this would be like, I don't know, a torturous scenario. Say you have to give neostigmine, you should still pair it with your atropine or your Robenal, okay? Because just because it will not have a cardiac effect, they're still going to have parasympathetic effects, okay? They're still going to have, they may still have all of the other not so great effects. Ideally, Gamedex and a steroidal neuromuscular blocker, but know that if you have to absolutely use neostigmine, still pair it, okay? Preload dependent, okay? They're really not able to respond to those shifts in volume. General over neuraxial, because they're going to have that impaired response to hypotension. TEE is very useful. Use a nerve stimulator. Once again, big fan of use some Rock and Gamedex. Okay, vasoplegia. So if you have somebody who's vasoplegic, okay, methylene blue, earlier rather than later. Norepi, vasopressin, okay. The take-home message, methylene blue, earlier rather than later, okay. Can be very, very useful. Keep that in mind. What are they going to look like afterwards? Depending on how much you use, they may be a little dusky. We gave somebody methylene blue not that long ago, and they looked like a Smurf for a couple hours in the PACU. It's pretty terrible. When I brought a patient through, I thought, who left the corpse in Bay 7? Like, oh no, we give methylene blue. I'm like, well, yeah, you can tell. All right. So let's talk a little bit about EKGs. I know we've talked about EKGs in the past. We're going to get a little bit deeper on a few things. And, the truth is, you're not going to get away from CAD. Not in this part of the country, at least. Okay? 1/3 of patients scheduled for non-cardiac surgery have risk factors for coronary artery disease. Okay? The overall incidence and perioperative ischemia for these patients, 1 in 5 to 4 out of 5. Really depends on who's doing their anesthesia. If it's me, it might be that 80% of you might have it. If it's somebody else, maybe 1 in 5 will have it. If it's doing really, really good, maybe it's 1 in 10. All right? But we should be ready and prepared. Okay? We should know how to recognize ischemia. All right? And this can be completely missed if you're not looking at 2 leads. Note this, and I find this highly worthy. Dysrhythmias occur during about 70% of all anesthetics and are associated with pathology along with anesthesia. So we are possibly the cause. All right, let's talk cardiac action potentials. Okay? So we're going to look at first, note this image. This is the fast cardiac channel. So how I've always been taught, okay, so start at phase 0. Okay, phase 1, this is more of that academic plane. Okay, all right. As you go to phase 2, phase 3 is going to be recovery. Phase 4 is back to baseline. So with the cardiac action potential, this is how heart cells are going to send and transmit electrical signals. So these are created when charged particles or ions move across that cell membrane. So when the heart cell, okay, is at rest, it's polarized. The inside is more negative and the outside is more positive. Heart cells can initiate, okay, or start and conduct or carry out an action potential. Fast channels send these signals very quickly through the cardiac muscle, and slow channels are often found in the pacemaker cells that help start the heartbeat. So phase 0 is that rapid rise. Sodium rushes in, and you get depolarization. Phase 1, like I said, it's a very academic thing. You get a little drop, you've got some ions leaving. Then you have your phase 2, that's your plateau phase. Calcium is going to enter, it's going to help balance that charge. Phase 3 is whenever you're going to see that drop. You have potassium leaving, you get that repolarization. Okay? And phase 4, it's resting and it's ready for that next beat. Okay? So from an anesthetic standpoint, understanding this is critical for the drugs that we give that especially influence cardiac excitability and conduction. Okay, cardiac cells are unique in that they can self-generate. Okay, that's that automaticity, and conduct impulses, or that conductivity. All right. So fast channels are primarily sodium dependent and are involved in that rapid impulse conduction and working myocardial cells, whereas slow channels are calcium dependent. And that's crucial for impulse initiation, okay, especially in your SA and AV nodes. So anesthetic drugs, think your volatiles and your beta blockers. These are great at depressing these channels, affecting heart rate, rhythm, and conduction. It's all very useful in everything we've talked about thus far. Okay, fast potentials. This is what we think of when we think about an action potential. Depolarization is slow through the AV node, and then that spontaneous phase 4 depolarization in the SA node. So fast potentials, these are going to be found in your atria and your ventricular myocytes, as well as your Purkinje system as well. And these are very reliant on that sodium influx. Okay, phase 0 for depolarization, that's that quick conduction of that electrical impulse throughout the myocardium. They're fairly uniform and synchronized for contraction of your atria and your ventricles, and it's dependent on these fast conducting fibers. Okay, this is essential for coordinating that mechanical contraction. Okay, and this is really the basis of our QRS complex. Okay, slow potentials, okay, those are your pacemaker cells in your SA and AV nodes. Slower depolarization, calcium rather than sodium. All right, and these slow potentials, they have some essential properties. Calcium-mediated depolarization, slow conduction, especially in the AV node, spontaneous depolarization during phase 4. Okay, and that last one is very vital, okay, because that makes the SA node the dominant pacemaker under normal physiology. But what do our anesthetic agents do? They can depress nodal conduction, especially in the AV node. And this leads to often bradycardia and heart block. Okay? Especially in cardiac surgeries, you block your cardiac fibers with a high spinal, you'll start to see those arrhythmias. Okay? So, once again, phase 0, that rapid depolarization. So if we want to slow this down, we can give a sodium channel blocker. Okay? All right. Phase 1, that rapid partial repolarization. It's a very academic thing. Phase 2 is that current running down the Purkinje system. Okay? Phase 3, that rapid repolarization. Okay? You've got potassium extrusion. And then phase 4, depending on the activity of the cell, okay, that resting potential and spontaneous depolarization may occur. Okay? Sodium, calcium, and potassium blockers affect the fast potential. Okay? So keep in mind, fast cardiac action potentials are characteristics of your atria and your ventricular myocytes, as well as your Purkinje fiber system. All right? So, sodium influx, phase 0, that depolarization. Okay? That small, rapid, but partial repolarization in phase 1, followed by phase 2 with that calcium influx to support your contraction. Phase 3 is going to be your potassium efflux, leading to repolarization, and then resting potential is maintained in phase 4. So, it's called fast because it moves quickly due to that sodium influx. Now, those slow potentials, that slow calcium influx, there's no phase 1 or 2, and phase 3 is really not significant. Okay? Phase 4 is depolarization, and these are the pacemaker cells of the heart. Those slow action potentials occur in pacemaker cells and the SA and AV nodes. they lack that phase 1 and 2, and their depolarization is gradual due to that calcium rather than sodium. Phase 0 is caused by the inward movement of calcium through the L-type calcium channels, and that's that slower upstroke velocity compared to the fast potentials. While phase 3 is the potassium efflux, all right, it's really not that significant, while phase 4 is that spontaneous depolarization. And this type of automaticity is critical for getting that consistent rhythm. So from our standpoint in anesthesia, slow potentials are very sensitive to calcium channel blockers, beta blockers, and a number of anesthetics that are known to depress that automaticity and conduction. Esmolol, high-dose volatiles, these slow conduction through the AV node. This increases your risk of heart block in somebody with a pre-existing conduction abnormality. Okay? So it's very important to understand that phase 4 depolarization when we're using these agents that can alter autonomic tone. Spinal and epidural are huge here because this can unmask some bradyarrhythmias, especially due to vagal dominance. So what do we do with all this? Why does this matter? Well, these are the sites of action of a number of our major antiarrhythmics. Okay, so class 1 sodium channel blockers work on those fast action potentials. Beta blockers in phase 2 and phase 4 for that rate of spontaneous depolarization. Your class 3 potassium channel blockers work on that potassium extrusion, and to a small degree the SA and AV node. And class 4, those work on the contractility portion and help slow things down. Okay, so be very familiar with where these drugs work. Okay, it's important that we keep this in mind. So key points. Class 1, sodium channel blockers, they slow that conduction, phase 0. Class 2, your beta blockers, phase 4, they decrease your SA and AV node activity. Your class 3 or your potassium channel blockade, phase 3, they prolong that repolarization. And then your class 4, your calcium channel blockers, we're looking at phase 2 in the myocytes and phase 0 in that nodal activity. Okay? That's the most important part. Okay? Knowing where our drugs work. So let's talk about conduction in the heart a little bit. Okay, our SA node fires 60 to 100 times per minute. Okay, it's going to travel down the AV node, and like a cop in traffic, it's going to slow things down. It travels fairly uniform down through the ventricles. All right, it's going to cause a wrenching motion, and that's why it's important to have that symmetrical conduction pattern, especially in heart failure, and that's why we have that resynchronization therapy and device, and we just don't overstimulate that right ventricle. Okay, it should squeeze both ventricles at the same time, and then all the cardiac cells are stimulated pretty much simultaneously due to the speed of the system in a normal heart. Okay, let's walk through this. Cardiac electrical conduction begins at the SA node, and it's got the highest rate of spontaneous depolarization. It's the primary pacemaker of the heart. It travels through the atrial myocardium, those internodal tracts, to the AV node. It's going to slow things down the traffic cop. All right, it's going to give time for ventricular filling, and then that impulse will quickly move through your His bundle, your bundle branches, Purkinje fibers, and coordinate that ventricular contraction. This is crucial for us, specifically in anesthesia. Think about drugs like atropine, ephedrine, isoproterenol. They can be used to counteract some of those AV nodal delays. All right. There are anesthetics that we give, like beta blockers or calcium channel blockers, that prolong AV nodal conduction. You have to be very careful in somebody that has any conduction abnormalities or an implanted pacemaker. Okay? And this is going to lead us to recording of the EKG. Limb 1, okay, shoulder to shoulder, a positive and a negative. Your limb leads 1, 2, and 3. So we're recording the electrical activity of the heart. Okay? Each lead is bipolar. Okay, it's going to measure the electrical potential between 2 points, one positive, one negative. That's going to create a vector. Okay, and that's the direction and magnitude of that depolarization. Okay, limb leads 1, 2, and 3. You might hear Einthoven's triangle. Okay, you'll see that thrown around a little bit, especially if you read Dubin. This provides different angles of cardiac electrical activity, and these are very essential for evaluating rhythm, access, and ischemia and conduction delays. This is critical for us in monitoring patients with cardiac disease, those undergoing cardiac surgery, especially looking at ST segments, PR intervals. Vector-based readings help to identify the location of injuries. Think about an inferior wall MI, and proper electrode placement is crucial. All right. EKG leads are positioned on the chest and the extremities, okay, with the V lead placement dependent on whether a 12 lead or a 5 lead is being used. Okay, 5 lead is normally what we're going to be using in the OR, especially if somebody has cardiac disease. You can use a 3 lead. All right, but that should probably be reserved more for outpatient cases for someone who does not have those risks for ischemia. Lead 2 and V5 are the most useful. Lead 2, because it cuts across the atria, and V5, it's going to monitor the largest part of the heart at risk for ischemia, the anterior wall. Lead 2 is going to see your largest P wave voltage. We get a lot of information from that. Okay, you can get left and right atrial hypertrophy. You can really see your AFib or your nodal arrhythmias. And then the older halogenated agents, okay, halothane, is it isohexafluorine? Some of the older agents were more common to cause these nodal arrhythmias. Not so common in DES and SIBO, okay? Has anybody used ISO? Okay, a little bit, yeah. You know, ISO is kind of that line of, you know, because 30 years ago, ISO was the quick drug. You want to wake somebody up fast, that you used ISO. Probably 35 years ago, SIBO was out then. But you'll see the older agents caused more of those nodal arrhythmias. Lead 2 is parallel to the electrical axis of the atria. All right. And it's the best to diagnose atrial arrhythmias. Know that. Lead 2 is the best to diagnose atrial arrhythmias. Okay. Lead V5, lies over the 5th intercostal space, okay, at the anterior axillary line, and is the most sensitive for detecting anterior wall ischemia and infarction. A 5-lead system is required for a true V5. If you monitor lead 2 and V5, it should be done simultaneously, and 80% of all ischemic events can be detected. Okay? If you can only monitor one, because you're working in an ASC in Kentucky, you have a 3-lead system, all right, you should pick which lead to monitor based off of your patient's history and anything that would put them at risk for ischemia, okay? So lead 2, strong P waves, all right, V5, all right, anterior axillary line, anterior and lateral wall ischemia. Monitoring multiple leads is very useful, very amazing. And ideally, you can view multiple leads at once, because sometimes you can miss, okay, ST segment changes on just 1 lead or 2 leads. ST segment changes should be observed and compared to, ideally, a preoperative 12 lead if you have somebody at risk. All right, so if we were just looking at V5, all right, and we weren't looking at 2 and 3, you're not going to see that ST segment. You're not going to see those changes. All right. We all know this. If you don't, learn it now. Okay? Know your P wave, know your intervals, your QRS, your QT, your ST, and your T wave. Know your timing as well. Okay, so focal points here. Focus on size of your P waves, your PR interval. Many of our drugs affect this, okay? And this directly affects AV conduction. And then the QRS interval as well. Our drugs often affect conduction as well. Okay, these are the areas we're going to focus on. Identify the rhythm and rate. First off, is it regular or irregular? Is there a P before every QRS? Are there abnormal beats, or are they ventricular or atrial in nature? Okay, however you decide to calculate it, it's fine with me. Do you count the big boxes, divide by 300? Do you count the smaller ones and divide into 1500? Do you count a 6-second strip and times it by 10? Whatever you want to do, however you can do it, you know how to calculate it. Okay, your PR interval. Okay, normal is 0.12, okay, to 0.2. All right, 3 to 5 small squares. Shortened PR interval, this could be Wolf, Parkinson, White. A long PR interval greater than 0.2, first degree. With that, first degree AV block. See this a lot in the elderly. All right, rarely does this affect hemodynamics, okay, but it can impact some ventricular filling, all right, but it's fairly benign, okay. If your EF is less than 30% and your QRS interval is increased, you may need some cardiac resynchronization. New changes to your bundle branches and their conduction is a sign of ischemia, or it could be a sign of drug toxicity, ion imbalance. Remember that your QRS complex is a representation of that rapid depolarization of the ventricles. Okay? A prolonged interval suggests impaired conduction. Okay? This is a intraventricular conduction delay. In complete bundle branch blocks, if the QRS exceeds 120 milliseconds, all right, incomplete blocks fall within close to that upper limit of 120, but this all just reflects a slowed electrical conduction, okay, and this can cause some asynchronous ventricular contraction, which will reduce cardiac output. Know your bundle branches, okay? The widened QRS complexes, they have distinct morphology. Right bundle branches, okay, show that characteristic rabbit ear pattern, okay, normally in leads V1 and V2, while left bundle branches show that broad or notch, that slurred R wave in those lateral leads, maybe some deeper S waves in your V1 and V2 leads. Okay, recognizing this is very vital in not only a preoperative evaluation and intraoperative monitoring. A left bundle branch block, okay, can obscure your ST segment changes, masking ischemia. New onset, left or right bundle branch block can indicate a perioperative myocardial injury or conduction system compromise, okay? But that does not necessarily have to be the case. Assess your patient. Ask them questions. Have they had new changes, okay? Identifying these patterns are very, very useful. Okay, somebody that comes in with a bundle branch block that has greater than 4 minutes, that does not have chest pain, certainly you should probably have a baseline EKG, but should they be canceled and sent to a cardiologist? Probably not. Now, if they have, you know, if they've reported chest pain, if they have any other reason for workup, all right, that should be something to consider, but the majority of the time, baseline benign findings, probably okay to proceed. QRS access. Once again, this is a very academic point. Nagelhout really talks and dives into a lot of these things. I'm not big on testing over axis deviation, but from QRS axis from ischemia conduction can be abnormal. It really just reflects the direction of that ventricular depolarization. Know that normal is -30 to +90. Deviation occurs and changes to the myocardial mass, so a type of hypertrophy or a conduction abnormality. Left axis deviation, okay, is between -30 and -90, and that's typically from an anterior fascicular block or left ventricular hypertrophy, while right axis deviation, okay, +90 to 180 is commonly seen in right ventricular hypertrophy. That indeterminate axis, that's we need something else is causing this. We need to look in this a little closely, okay? Once again, not going to be big on this, but you should at least know your normals and then what can be seen in left axis and right axis deviation. The QT interval. Everything we do or touch is going to affect the QT interval. It's very rate dependent, okay? What's the big one that we always think about when we talk QT interval? Zofran, okay? But pretty much everything you give is going to affect it, okay? The QT interval represents the time from ventricular depolarization to repolarization. It's rate dependent and has to be corrected for heart rate using the QTC formula. So the upper limit is normally 450 to 460 milliseconds. Prolonged puts you at risk for ventricular arrhythmias, especially torsades. QT interval monitoring is vital that we know how to do it, especially when using a number of our drugs: volatiles, droperidol, Zofran, methadone, hypokalemia, hypomagnesemia. These are all conditions that can affect our QT interval. So, QT prolongation. This can be inherited, this can be acquired, this can be from electrolyte abnormalities, this can be from hypocalcemia, hypomagnesemia. These are all common causes, and ideally your electrolyte abnormality should be corrected in the perioperative period. Okay. Structural heart disease, acute myocarditis, heart failure can predispose you to QT prolongation. Okay, your class 1 and class 3 antiarrhythmics, tricyclic antidepressants, okay, and like I said, Zofran and droperidol. Okay, know what can cause QT prolongation. Okay, this could be genetic, cardiac injury drugs, HOCM, myocarditis. Know these. Shortened QT interval, not often seen. It really messes with your J point and your segment analysis. This can sometimes be from a digitalis effect. Okay, I love this saying. I get it from one of the people that I aspired to be like one day. Overuse of calcium is a sign of the weak mind. All right, you'll see a lot of times people reach for calcium pretty quickly for treating hypotension. Overuse of it is not good. Shortened QT intervals are less commonly seen, but they're pretty significant. Hypercalcemia and hyperkalemia are primary causes, okay, and should be considered when electrolyte abnormalities are present. Hyperthermia and malignant hyperthermia, along with sepsis, can shorten the QT interval. Vagal stimulation and digitalis can contribute to this as well. All right. So in anesthesia, recognizing that shortened QT interval is important for evaluating someone with altered mental status, arrhythmias, unusual patterns. Elderly patients, you may think, are they on digoxin? All right. Is this vagal reflex from surgical manipulation? And then that altered J-point relationship could falsely give you a potential for an MI, and so you have to carefully interpret this. P-wave assessment. Okay, should always be positive in leads 1, 2. It should be negative in AVR. Left atrial enlargement from mitral valve disease, left ventricular failure with regurgitation, right atrial enlargement from tricuspid insufficiency. P-wave analysis is crucial. Okay, a normal P-wave is less than 0.12 seconds. All right, right atrial enlargement produces tall peaked T waves, while left atrial enlargement presents as that notched or that bifid P wave in lead 2 and can be seen as biphasic in V1. Okay, this is where we're assessing our atria and structural heart disease. Know what a normal P wave should look like and when you might see a biphasic one. Okay, the normal QRS pattern, it has a normal progression. Your R wave should get taller and taller as you progress from your midpoint to your mid-axilla, and your S wave becomes taller. So in a normal EKG, and I'm talking about precordial leads, V1 through V6, there should be a predictable R wave progression where it increases in amplitude from right to left, okay, V1 to V6, okay, because the vector of depolarization moves through the ventricles. So you'll see R wave progression, and this is a healthy conduction. A loss of progression or flattening, you'll see that called poor R wave progression, can suggest ischemia and anterior MI, oftentimes lead misplacement, okay, or some potentially benign factors, okay? So for us, identifying abnormal QRS patterns is critical, especially if we're intra-op doing a 12 lead. Pathologic Q waves are indicative of a prior MI. Intraoperative detection of new Q waves or poor R wave progression should raise concerns for perioperative ischemia. This is more important than R wave progression. Okay, left ventricular hypertrophy, right ventricular hypertrophy. LVH, aortic stenosis, HOCM, hypertension. Right ventricular hypertrophy could be that eccentric hypertrophy. So you see that S wave and V1 or V5 and V6 for your P, think P for pulmonal, in your right ventricular functioning from pulmonary hypertension. So left ventricular hypertrophy, all right, large QRS voltage, S wave and V1 plus the R wave and V5 or V6, all right. Right ventricular hypertrophy, tall R wave, right axis deviation, right atrial enlargement, think pulmonal. So this could be chronic pressure overload from either hypertension or pulmonary disease. Hypertension more left ventricular, pulmonary disease more right ventricular. It's important that we understand this because this increases our risk for arrhythmias, all right, the need for detection of ischemia, especially from stress. Left ventricular hypertrophy can cause some diastolic dysfunction and cause some fluid shifts as well. While right ventricular hypertrophy complicates the ventilation due to that risk of heart failure, don't let that CO2 build. Recognize these patterns. Tailor your fluid management, your hemodynamics, along with your vent settings. Okay, right ventricular hypertrophy. If you're macking these patients and you're not monitoring your CO2 and you're hypoventilating them, all right, this is where you'll start off and they're not needing any pressors, and all of a sudden, man, I'm having to give 2 or 3 cc's of Neo every time my blood pressure cuff cycles. What's happening? All right, ST segment analysis. Okay, ST segment should be flat, okay, or isoelectric, but they should be calibrated. This is the period between ventricular depolarization and repolarization. Deviations are normally significant and suggest ischemia or infarct. The J point, okay, and you should know where this is, marks the end of the QRS complex. The ST segment is measured 60 to 80 milliseconds after the J point, okay, and accurate identification is essential if you're really detecting myocardial injury. This is crucial. This is why you have to have a baseline value. This is why your leads have to be placed appropriately, okay? There is nothing worse than saying, calling out to the desk for another CRNA and anesthesiologist, someone to come in there, hey, I think we had some EKG changes. They come in, they look, okay, hey, let's move your lead, let's check. Okay, all right, that looks pretty normal to me. Yeah, it does, okay? Make sure you're placing your leads appropriately, okay? If you're looking at your baseline, if you get in the OR and you don't like what you see, make sure that they're placed appropriately. If the nurse put them on, if someone is helping you, pay very close attention to that. And sometimes you'll find yourself doing, hey, you do this so many times, you may find yourself putting things, just going through the motions, putting things in the wrong place. So, evaluating the ST segment. Find the J point, look for the isoelectric line. Okay, this is a very qualitative assessment. Okay? For us, if you detect ST elevation intraoperatively, this can become a medical emergency. This could signal ongoing infarction. Okay? So, if something changed intraoperatively, if you had sudden hypotension, all right, if you had tachycardia that you managed and now you have ST changes, all right, pay close attention. If you're coming off pump and you didn't have ST segment issues beforehand and all of a sudden you are, all right, this can be a big deal. Accurate assessment. Make sure your leads are in the right place. All right. There are some settings you can do to calibrate, modify your ST segment settings. It has to be optimized to avoid misinterpretation. You can adjust your reference points. Once again, this is a very qualitative assessment. Okay, it's a great mystery of why Nagelhout loves gain and frequency so much. I don't think it's really that important for us, but there are gain and frequency and filter settings that can impact the accuracy of our segment analysis. Okay, standard gain is that 1 millivolt, and it's going to yield a 10 millimeter detection on the monitor. Filtering excessively distorts your ECG and obscures your ST deviations and your diagnostic value. Okay? So when evaluating for ischemia, the diagnostic filter setting should be used instead of filtered. Diagnostic. Okay? Because if it's filtered, it could remove critical low-frequency components. Non-STEMI versus STEMI. An MI is an MI, right? Okay, STEMI is a big deal because they're at risk of VFib, arrest, death, emergent cath lab needs. Non-STEMI, that's more of that cardiac event, that chest pain, think nitro drip, non-emergent cath lab. Non-STEMI is going to present with that ST depression, T-wave inversion, okay, or transient and non-specific ST changes. They lack those pathologic Q waves, okay, and usually have a preserved R to S ratio. This is a clinical presentation, EKG, cardiac biomarker, diagnosis. STEMI, on the other hand, marked by a persistent ST elevation, pathologic Q waves, and this is full thickness myocardial infarction, okay? Distinguishing between these two in the OR is critical. Non-STEMIs can be managed conservatively with some delayed intervention, while STEMIs require immediate and urgent action. Sudden ST elevation intraoperatively means we have to rapidly assess our hemodynamics, ensure we are optimizing oxygen delivery, okay? Potentially cardiology notification, okay? Knowing these patterns ensures fast, life-saving response. If you are detecting a STEMI and you're in the OR, all right, that's probably one of the worst places to have it. Okay, simply, a hospital is the worst place to have a heart attack, all right, because you can be complaining of chest pain for hours and hours and hours, and nurse finally does an EKG, okay? It's a lot easier when you're at home and you just call 911 and EMS comes and picks you up and takes you to the ER. So in the OR, okay, make sure you're assessing things. If it's a STEMI, urgent intervention, call cardiology. If this is a procedure that can be stopped or finished quickly, that should happen, okay? So here's our thresholds for values of ST segment elevation, okay? The big things, note the J point elevation, okay? Less than the age of 40 requires a little bit more. T-wave assessment. Has some utility, it's mainly electrolyte abnormality. When we interviewed, I probably asked some hyperkalemia questions, some T-wave questions. It's one of my favorite things to ask. T-wave, think ventricular repolarization. It should be symmetrical normally. The first half having a slower, more gradual slope, and the second half descends a little bit more rapidly. Okay, it should be about an eighth, okay, but less than 2/3 the height of your R wave, and it rarely exceeds 10 millimeters in amplitude. It should follow the direction of your QRS complex, and tall, peaked, biphasic, or inverted typically indicates electrolyte imbalances, ischemia, or CNS disturbances. Okay, T-wave abnormalities are significant to us because we can detect some early ischemia, especially in high-risk patients. Tall peak T-waves are the hyperkalemia, think succinylcholine, administration, renal dysfunction. Inverted or biphasic can indicate ischemia or pericarditis, and we may need some hurried intervention. Okay, the U-wave, who knows? Is it hypokalemia? Is it decreased heart rate? Is it a young patient? The U-wave should follow the same direction, okay? The U-wave represents after depolarizations that occur after ventricular repolarization. That's a mouthful. The U-waves represent after depolarizations that occur after your ventricular repolarization. Normally seen in lead 2, that small, round, symmetric waves that follow the T-wave and share its direction. They're normally less than 2 millimeters. They become more prominent as the heart rate slows, or especially in hypokalemia. Often benign, that can signal drug toxicity or long QT syndrome. Be aware of U waves and electrolyte disturbances. They can put you at risk for torsades. Okay? So if you haven't stabbed your eyes out yet, there are a number of pathologies that affect our EKG pattern. Hyperkalemia and hypokalemia. Okay? Drug toxicities, think digoxin. Myocardial infarction, dysrhythmias, pericarditis, hypertrophy. These can have distinct EKG changes, changes in our number of waves and our complexes. You have to interpret these appropriately. Be vigilant, monitor these, okay? Know the common ones, all right? And my favorite thing to tell people is you should know what is normal and what is abnormal. If your gut tells you, hey, this is a change, this isn't right, look closer at it. Hyperkalemia. I've seen a potassium of 8 something before, profound T wave. This is terrible. If you've missed this, this is a big mistake. That widened QRS happens. If you ever have someone that inadvertently, hopefully you're never involved in this, but if someone tries to do a beer block with Marcaine, and you get that wide QRS complex, that slow heart rate, that hypotension, or even if they do a dense field block with Marcaine, okay, if they inject a bunch of it, they're not paying attention, or they think they're injecting 0.25% and they're using half, you can see those big changes. So hyperkalemia, all right, tall peak T waves. Okay, as the potassium level rises, that P wave amplitude diminishes, your PR interval lengthens, and your complex widens, your QRS complex. This can merge into that sine wave pattern, and that's impending cardiac arrest. Okay, insulin and D50. All right, the clinical effects of hyperkalemia. This can lead to fatal arrhythmias. Okay, this can lead to that widened QRS, asystole. Okay, so if you see that sign pattern, impending cardiac arrest, calcium chloride to help stabilize the cardiac membrane, insulin with glucose, okay, to drive that potassium into the cell, and sodium bicarb if they're acidotic. Okay, diuretics, albuterol. There's other things you can do, but for a quick treatment of hyperkalemia, insulin D50. Okay. Hypokalemia prolongs that QT interval and predisposes you to torsades. You're normally going to see a prominent U wave. Hypocalcemia and hypomagnesemia lengthen the QT interval and increase the risk for VFib. Elevated magnesium, and you'll see these women in OB that have been on a mag drip for hours and hours and hours. They lose their deep tendon reflexes. But elevated magnesium can slow that conduction. And normally you're going to see this in your OB patients when you're caring for somebody who's preeclamptic. Hypercalcemia shortens the QT interval and can mimic a digitalis effect. All right, recognize these things and know when to send some lab values off. Cardiac arrhythmias can vary from incidental to benign, all the way to life-threatening. It's typically from an abnormality in impulse formation and conduction, and we are going to base and classify rhythms on rate, origin of disturbance, impulse conduction, and phenomenon. Bradyarrhythmias, tachyarrhythmias, heart blocks, other conditions as well. Be familiar with these. Okay? The mechanisms of dysrhythmias. In anesthesia, especially in older adult, there are agents that sensitize the heart to epinephrine, think local with epi, stimulation. All of our volatiles affect conduction. So mechanisms of dysrhythmia, we have altered automaticity, impulse, conduction disturbances, and triggered activity from after depolarizations. So if you're having surgery, getting anesthesia, guess what? It's not healthy. It's stressful. There's pain. There's trauma. These can all change the slope of your cardiac action potentials, not even including our drugs. Okay, your SA, your AV node, Purkinje fibers may increase or decrease your firing rate. Normally, those non-automatic cells develop that phase 4 depolarization, and this can be from stimulation, ischemia, electrolyte imbalance. These are all things that can disturb automaticity. What are some things that cause tachycardia? Oh, the Millard and the Mac blade. Okay. What do you want your blood pressure? 3/2. Okay. Your systolic, greater than 100. Your diastolic, less than 99 or less. Okay. Ventricular hypertrophy. These are all things that can cause some sinus tachycardia. Active MOM is a good mnemonic. Okay. But we know all these things. You should be familiar with them. What causes bradycardia? All right, think about the eye and the muscles around it. Okay, asystole and bradycardia. Guess what? Laryngoscopy can do the same thing. You can get a vagal-mediated effect. Okay, when you do a big narcotic induction. Okay, you've blocked all that sympathetic response. You go to DL and you'll get asystole from it. Succinylcholine. All right, you can get a decreased heart rate. You can get bradycardia from sucks. Okay, beta blockers, calcium channel blockers. Okay, sucks, that parasympathetic effect. Hypothermia, hypothyroidism, a good athlete. These are all, SA node ischemia, these are all things that can cause bradycardia. Okay? Disturbances of conduction, think AV blocks. Okay? Think about a TAVR, okay? This is going to put pressure on conduction pathways. 30% of TAVRs are going to get a pacemaker. If they come in, note this down. If your patient comes in with some degree of heart block, ideally avoid lidocaine in your induction sequence, okay? So AV block, heart blocks refer to impaired conduction impulse through the AV node, leading to varying degrees of heart block. First degree, the impulse is delayed, but all of it reaches the ventricles. Second degree, some are failing to conduct. And then complete heart block, third degree, no impulses are getting through. That's that disassociation. Second degree, type 2 is more dangerous. Okay, so Mobitz type 2. There are several perioperative factors that influence our AV blocks. Lidocaine, beta blocker, sucks. Myocardial ischemia, hyperkalemia, hypothyroidism. So pay very close attention to that. Ideally in an AV block, probably avoid your lidocaine. Okay, disturbances of conduction, stress, adenosine, reentry tachycardia, AV nodal disturbances. Reentry occurs when that electrical impulse circulates through a loop, all right? And this is due to a conduction velocity and refractory period effect. This normally requires at least two pathways with differing properties, and if you have a reentry circuit, one pathway conducts it more slowly, all right, while the other is a little bit quicker, normally in an antegrade and then a retrograde conduction. This imbalance causes the signal to reenter and begin that loop, okay? This is very common in a tachyarrhythmia like Wolff-Parkinson-White. Physiologic or pharmacologic changes can disrupt this balance and induce arrhythmias. After depolarizations, this is more of kind of interesting, that R on T phenomenon. These are the oscillations in the membrane potential that occur during or immediately after repolarization. They can be early or delayed, depending on when they occur. And especially in specific scenarios, like think of a electrolyte disturbance, drug effects, or ischemia, these can trigger new depolarizations. Okay, and if the depolarization reaches threshold, that's whenever you get that premature contraction and potentially a sustained dysrhythmia. So these include ventricular tachycardia, SVT, A-flutter, okay, AV nodal reentry tachycardias, and this really plays a critical role in identifying your arrhythmias, especially in conditions when you may have that prolonged repolarization, think like long QT syndrome, and you may also see some electrolyte imbalances as well. Okay, so medications. All of these things can influence and cause arrhythmias. Think your diuretics, think your thiazides, your potassium sparing, your loop diuretics, how they will decrease or increase your potassium. Your sympatholytics, your adrenergic blockers, your alpha agonists, all of these drugs, how they have an effect on your heart and your heart rate. Your vasodilators as well. All patients with a prior MI should be on a beta blocker, and ideally an ACE inhibitor, okay, if hypertension is present, okay. If they have moderate to severe hypertension, this may require multiple medications. One of the best things you can do if your patient is hypertensive in the PACU is give them their daily meds, whatever they've missed, whatever they didn't have. All right, we talked about the vasoplegic syndrome. I want to emphasize this again. Methylene blue has been shown to treat that refractory hypotension. Okay, and how it works is it prevents that vasodilation due to blockade of that nitric oxide synthase. 1 to 2 milligram per kilo. You can give it an infusion. Think ACE inhibitor, vasoplegia, very, very useful. Okay. Alpha-2 of your pharmacologic management. Think about using your alpha-2 agonists, clonidine, Precedex, how these can be very useful in maintaining and controlling that heart rate. Be careful about the transient hypertension if you're giving them up front, okay? Make sure that they've had their statins the day of surgery, how they stabilize everything. This is very, very important. All right, and finally, okay, I'm gonna emphasize this again. Treat intraoperative hypertension, okay, by focusing on the cause. If it's pain, give narcotic. Okay, if they're light, increase their anesthetic depth. If they're hypoxic, increase your O2, increase your minute ventilation. If they're hypercapnic, increase your minute ventilation. Avoid long-acting antihypertensives, drugs like hydralazine, labetalol, metoprolol. Hydralazine has that delayed onset, okay? You're going to be stuck with a low blood pressure for hours. Reach for something quick-acting, okay? All right, that's it. Stolting, Barish, Nagelhout as well. And then, of course, the Miller sections. If you guys have any questions, please let me know.